This week on the Backtable Podcast.
The CTO crossing is the most important part of treating a patient with CLI. So in the vascular revascularization, really depends whether you get flow to the target organ, right? The foot. So if you don't get flow to the foot, you really didn't succeed. And no matter what you do. The catheters that are coming out from different companies right now, they have CTO modalities in them. They're not CTO catheters, but they're good for support. So this kind of things I would like to leave our colleagues with to think about these devices, because when we got them and we used them, it was like, wow.
Hello, everyone, and welcome to Backtable, your source for all things endovascular and more. You can find all previous episodes of our podcast on any platform like Spotify or our website, backtable.com. You can follow us on Twitter, Instagram, or LinkedIn and keep up with the latest updates and give us feedback through comments.
Now, a quick word from our sponsors.
For more than a decade, Reflow Medical has designed and engineered medical devices that respond to unmet clinical needs. The Wingman crossing catheter with its unique extendable beveled tip and an expanded indication for CTOs. The Specs LP, created to meet the need for a low-profile version of the Specs shapeable support catheter. And the new line of Core catheters that answers the call for a suite of effective tools to use in challenging PCI procedures.
Now, back to the show.
I'm Sabine as your host today, and I'm so happy and glad to welcome back a great friend and extremely talented cardiologist, Dr. Jihad Mustafa from ACV in Grand Rapids, Michigan. How you doing, man?
I'm doing very well, Sabine, and thank you. And I want to thank you and Aaron for putting this together, because this is something that is extremely needed. We all need it, including myself. We always learn something new when you put out something that we never thought of before, and then suddenly you discuss it and it becomes part of our practice. So thank you for doing all the work.
Absolutely. Thank you for taking the time. And I mean, we love learning from you, Jihad. I mean, you've done so much. The last time we sat and talked together on Backtable was almost 3 years ago. I mean, we talked about building a limb salvage program. I mean, that was episode 60 for all our listeners, a really, really good episode about building that program. And now it's 3 years later. What have you been up to? What has changed? What is going on in your life, Jihad?
You know, this last 3 years have been phenomenal 3 years because I definitely shifted from being a cardiologist into a CLI specialist. Stopped doing not cardiology in general, but interventional cardiology, and focused primarily on critical limb ischemia and PAD. And that field, CLI, is actually much bigger than I thought. And quite frankly, it's almost, you can say at one point, it will be its own specialty, because there's so much in it that we don't know, so much is unknown. So dedicated myself to it the last, 3 to 4 years have really changed my life in a very positive way.
That's great. That's great. And so I'm pretty sure everyone knows who you are, but for our listeners who don't, can you describe what ACV is and what is your general practice like?
ACV is advanced cardiovascular, and our practice initially started as a practice that is focused primarily on critical limb ischemia and peripheral arterial disease, and small part of it was coronary artery disease. And then as we grew and we got more cardiologists in, then we have now almost not split, but sort of have a cardiology department with interventional cardiology in it. And then we have PAD, CLI components. And it's kind of cool because our PAs, doctors, everyone that is caring for patients directly have become extremely knowledgeable about both. True. And then add venous into that. So I really enjoy reading HMP because our HMPs have become so long and so big, because you have to cover the cardiology components, PAD and venous, CLI. So we have grown to the point that we have encompasses the entire cardiovascular system in depth. And that made us, much better doctors.
And you've expanded too. I mean, you're even close to me now, you have a Vegas outpost and everything. It's really, really great what you're doing, Jihad. And today we're going to be, focusing on these complex revascularizations, lower extremity revascularizations, and utilizing some devices that can help us, in particularly re-entry devices when we're revascularizing a chronic occlusion.
Yes.
Now, my question for you, just to begin with, is what are some, basic techniques that we can just list and talk about that you use when you see a long chronic total occlusion? I mean, what are some things that are, any operator should kind of be comfortable with?
CTOs are never friendly, long, short, classified, non-classified. As long as you accept that right off the bat and knowing that you're going into a CTO and expect the unexpected, you're going to do well. So the basics of chronic total occlusions is approaching it from the best directions. For instance, up and over in the United States are now still actually the primary methods. So we do, initial angiography, up and over, take a look at the CTO, and then we do the wire catheter technique and try to cross with that. And then, quite frankly, we try like for maybe 5 minutes.
Yeah.
And if you don't make headways in 5 minutes, we tend to shift to alternative methods. If we make headways and we cross the CTO, but we can't re-enter distally, then we have multiple methods. And, Outbacks, Pioneers are really great devices. And I had the luxury of working with them for actually a long time and got to study them very well. They do help in situations where you have to re-enter in SFA or popliteal. It becomes more problematic when you go to P3 or the popliteal.
Sure.
But if you can re-enter without them, it's great. But if you have to re-enter with them, we can discuss, the pitfalls, the good and the bad, tips and tricks. And finally, one thing that I'd like to caution everyone of, CTOs are tricky. If you have a CTO that you measure and it's 150 millimeter, you should re-enter at 151 or 52 or something like this.
Not like 6 to 7 centimeters past the reconstituted segment. Yeah.
Yes. And if you can't do that, then you have to find another way. So we can talk about that as we go.
Well, I mean, we briefly touched. I mean, there's nothing like when you get really, I'm going to quote, lucky. I think it's lucky when you loop that wire, you get there, you're right next to where the reconstituted segment is, and then you straighten out the wire and boom, it goes luminal. You're just like, okay, like you mic drop and you're pretty much done with the case after a lot more steps. But yeah, I mean, we've all been there when you're doing these CTOs where you're trying the conventional technique. The wire is looped, and now all of a sudden the loop is extending. And when I'm saying loop, it's in the subintimal plane, and it's extending past that point. And that's where you start saying, okay, exactly, you want to come back where it's reconstituted. So you have talked about CTOP plenty of times before. I mean, is CTOP still something that the classification, is it something that you use on every single case?
Absolutely, Sabine. I mean, if you really want to be doing the safest thing for the patient, which all of us do, and we probably all do it subconsciously without knowing, even if we know the CTOP classification or we don't, every one of us probably think the same way. What is the safest way to reconstruct the CTO? So if you have a, type 3 CTOP, which you have an integrate convex cap, and retrograde side distally will be concave. So it's going to be difficult to come from above and the wire get deflected left and right at the proximal portion. When you see the wire coming down and suddenly hitting something and goes left or right, you have a problem there, right? And then this is where you have to decide, should I stick with the wire catheter technique here because I'm going to go subintimal for sure, or do something else? This is where the CTOP really helps. And then the other option would be if you have a nice convex CTO cap where the wire catheter go right through it, and when you get distally and the wire get deflected again, right or left, that's where you have to stop and think, how much do I want to mess with this vessel down here? Do I want to perforate it, dissect it, or should I go into alternative method as well? Alternative method would be, using Outback, using Pioneer. That's two methods that are known to be good and effective. But remember, the shaft of the Outback, some of the shafts are 80 centimeters, some are a little longer. So you have to be careful which one you pick if you pick it. So that's an advice I would like to give everybody. Make sure you check the shaft.
Something that I want to kind of go into is, we haven't mentioned yet, but pedal access. I mean, I think every operator now who's doing CLI are pretty comfortable with pedal access. And in our experience, before we go into, utilizing a reentry device, I would say in my practice, that 5 minutes that you're trying to do a conventional antegrade wire catheter technique, if it's not working, I think we, in my practice, go directly to pedal and start working that way instead of going to devices that you mentioned, Outback, Pioneer, and we'll talk about some more reentry devices. But do you typically go directly to pedal then? Or are you more favoring these reentry devices for a FemPop lesion?
I have not used a reentry device for many years now. In the past, we used them more, but then, we started to compare. We started to compare how long does it take, and the Outback for a while, if you remember, tip of it used to break when you go up on the horn. So they pulled it out, fixed it. The Elite now it works well. And the Pioneer, you can't always find it, right? There's always short of it. So since then, we, based on the complexity of our patients, if we don't actually recross within a few minutes, nothing is going to change, So we get pedal access or pedal access, and you take retrograde wire, 018 wire catheter. The surprising thing, Sabine, is like when you cross so quick, the distal cap, and you're in a true lumen, and you cross, it's like, what the heck, It took me 2 minutes to do this right now, and I've been struggling out there for more than 5 minutes usually. You start to feel like, okay, next time I'm not going to do this, and next time I'm not going to do it. So now, actually, if the CTAP classification is something complex, believe me, we start with actually pedal access. And, someone can criticize us for that. That's fine. It's appropriate. Because you don't know if you're going to cross from above. You should try from above first and then go with pedal access. But what we've learned with that is, and we'll publish some of this data as well from the PRIME registry. When you do it from retrograde and you cross the CTO cap, then you find out your CTO is not actually as long as you thought. And then you find that you're in true lumen more often than ever, actually, because of the IVUS.
Yeah.
So we shifted a little bit now, Sabine, where long CTOs, we start with the pedal access, come on up, cross the CTO cap, all the way up as far as we can, and then we'll stop before the reentry. And actually, if it just pops through, we'll finish it with TAMI technique. Yeah. But if not, we'll come from above and then do the flossing technique, and then from there.
And then go and finish off the case, right? But so where in that algorithm do reentry devices fit your, I'll be honest, we do a ton of CLI in my practice. We have, my practice is mainly diabetics, and so I have a lot of tibial disease, but I have plenty of SFA pop disease. But using pedal access, I have felt no need to take a reentry device out because we tend to be able to cross it with a wire and catheter. So I want to know for myself and for audiences what reentry devices are out there and why should I use them?
The most commonly available now, two devices that we're all familiar with are the Outback Elite and the Pioneer. And, there's actually some tips and tricks to them if you're going to use them. Mm-hmm. The Pioneer, when you're taking it up and over around the horn, you have to always respect it. And I tend to use it with 7 French sheath. You can push it through 6 French sheath, it's fine. And the reason I use a 7 French braided sheath, because when you go around the horn, you have to actually rotate the needle angle of the Pioneer that is facing down. So basically, it kind of rides the horn of the uroiliac junction, so you can advance it down and smoothly. Otherwise, it will be looking up. So the vector of force will be going away from the contralateral iliac artery. So small rotation, you advance and you take it down to where you need it to be. And then when you get there, also be patient, because when you're rotating the Pioneer, you have to wait for the force rotation to get there because you're going around the horn. And many of us, including me, don't do that. So this is one trick about the Pioneer. The other thing is, please always remember to use a non-hydrophilic wire with it, because if you use a hydrophilic wire, you know the consequences of that. So that's another thing that's very important. The Outback is similar to it, similar to the Pioneer. Make sure you always look at the shaft, the different shafts that come in, because you don't want to be going up and over, and then you have an 80 centimeter shaft versus 135, and then you want to re-enter at the poplite teal and you won't reach. Again, when you're taking these catheter above the iliac junction at the horn, the tips can break. So for the Pioneer, you can lose the value of the IVUS if you break it. And then for the Outback, if the tip bends, then you can lose the functionality of it, because it takes it away from the reentry component or the lumen. Becomes at a distance. So there's two things for them. And besides these two, there's not that many out there that will give you the good outcome that these two can give you. And when you re-enter, make sure you're not too far in a subadventitious space, because then you have an angle re-entering, and you don't want an angle to re-enter.
That's a good point. The angle can really mess things up.
Yeah.
What are some other re-entry devices? I believe there's Reflow out there. What are some other ones?
There's for instance, there's devices that was used in PQ bypass devices with limb flow, but these are not on the market yet. These are re-entry devices. They'll be in the market soon. And there's the Stingray, which is sort of like more like if you're truly just subintimal, want to get back in the lumen. And it's more effective when you use it in the tibials, popliteal. It's not very strong, kind of penetrating type of device, because it's not a needle, it's a wire that comes out. And now the last thing that we use, but it's off-label as a re-entry device, something called the Wingman. And the Wingman is made by a company called Reflow, and it's got a needle on it. It's a 035, 018, and 014. And the value of this device in our practice, I'm not saying it's off-label, it's not a re-entry device, but it's actually cool because you can actually bend it, shape it, and then use it so you don't have that 45 degree re-entry or whatever. You can actually enter it maybe 30 degrees if you want, or 15 degrees, based on the shape that you make. Other than that, there's not that much out there.
It's designed for to cross a CTO, right?
It's a CTO catheter.
Yeah, it's basically it centers you, and then you can push through. But you've used it in a re-entry. That's neat. You can bend it.
Because if you shape it, it retains the shape that you put on it.
Got it.
And the only time we use it is when we're struggling with other catheters. But then with retrograde access and the ability to use two-angled catheters, and the two-angled catheters, when you put them next to each other and you start to rotate them back and forth like this, what they do is they break the cap, and based on the C-top analogy of the cap, the type of cap you're dealing with, it doesn't matter how complex the cap is, nothing actually crosses the complexity of the C-top caps better than two catheters coming from two different directions on it. Because they're both in the lumen, and they just keep shaving out.
I call it battling of the wires, and eventually, to be honest, we barely even do a car. It's very rare I'll put a balloon up and try to make a space. I think two wires and angled catheters that are looped, and they're going around whatever circumferential subintimal plane you're in. Eventually, you're going to connect the two planes. You just have to work at it, right?
Yeah, we were very fortunate to be able to see it under ultrasound. So as you know, we use ultrasound intra. So you can see the catheters actually kind of demolishing the cap, right? And they getting closer to each other. And you can see sometimes just penetrating the other. And if you ask me about the time it takes to do this, it's actually a lot shorter than anything else. So long CTOs right now, no matter how long they are, our time to cross them is less than 10 minutes. It's not because we're good. It's because we use the technology that is available to us and allows us to see what we're doing, and we use the C-top. So you have data, you have technology. All you have to do is apply the two together, and then you can cross intraluminal a lot quicker.
Yeah. And I have two questions for you now. You mentioned one is that you've used re-entry devices for the tibials. Now, I've usually just thought re-entry devices are for FemPop. Have you used one of these devices in the setting of below the knee disease?
Yes, of course. The Outback more than anything else. Remember, the Outback is bigger and you have to be careful when you use it. And then the Stingrays, we use it more often. And that was years ago, before, maybe like 6-7 years ago. But since then, since we started to realize the ultrasound and retrograde access, quite frankly, we stopped using any reentry device since then. And not because of anything against them. The reentry devices are great. And if you're comfortable with them, you should use them. But for us, we found alternative methods where, you know, you're in the true lumen from retrograde, and the wire that is subintimal from antegrade, you just leave it where it is. And next thing you know is the retrograde wire just goes by it in the true lumen. And next thing
then you get it.
Cross. Yeah. So there's no need to re-enter from subintimal into true lumen in the tibial, because, you know, as you know, the data on that is really bad. I mean, it's poor outcomes.
Yeah, exactly. So my other question I was going to follow up on is about, you know, we talk about being subintimal and true lumen. You've mentioned it a lot. I mean, obviously, when we're using reentry devices or when we're doing these retrograde antegrade techniques, a large portion of our CTO is going to be subintimal. Do you have any problem? I mean, this has been debated many times and has been talked about, but do you have any problem with a long subintimal tract?
You know, I don't. As you know, as you said, for the longest time, they looked at, is there any value between putting a stent in a subintimal space versus in a true lumen in a long CTO? And the answer was no. That's actually stenting. That's not anything else. And that the resilience study was one of the best studies that showed, you know, basically if you're going to cross subintimal and re-enter, you got to stent and get a good, actually prepped vessel. When a stent is placed, it's very well opposed. The sizing is 1:1 or 1.1:1, and you get a good result with that. If you don't prep the vessel well, then subintimal recanalization with a stent may not be the best option.
I completely agree that a stent is needed in the you know, I've seen some, you know, people, even in my own practice, some of my younger guys that have recan and then angioplasty and DCB, but you can see if you IVUS that, it's just like it's a freaking Martian landscape, you know. I'm like, that's not going to stay open, even if it looks decently okay on angio. So stenting is very, very important. You know, one situation I found that I do use a reentry device, or at least try to, is a FemPop CTO with a single vessel runoff being the perineal. That one, I think there is a very good, you know, argument to maybe try a reentry rather than direct perineal access, which is what we do too. But I think a reentry might be better in that situation. What do you think?
I want to say 100%. I agree with you 100%. If you have a single vessel runoff and, you know, you can re-enter as far away from perineal as possible, do it and do what you have to do and get out. And I personally, right now, if I have that situation and I cross and the patient does not have any wounds, I tend to use either drug-coated balloons or drug balloon stents in that FemPop, because the long-term patency, like if you put an Iluvien or any other, whatever your favorite is, I'm not going to actually mention many names. Drug balloon stents versus drug balloon balloons, right? Based on how complex that lesion was, you can make a decision, because now that you have a single vessel runoff to the foot and you give it a good, nice, juicy inflow with high blood volume, you know you're going to have good long-term patency with drug balloon technology. On the other hand, same scenario that you just mentioned, we do what we call a Schmidt access technique, where we access an occluded artery, especially the PT, and we go through it on the ultrasound and we cross. And you'd be surprised actually how often we cross very quick and then go up and cross the distal cap and then reconnect together. And the nice thing about that is, again, to our surprise, we'll find ourselves in a true lumen in the SFA popliteal.
That's great.
More. Yeah. And then we can see the wire and IVUS in the subintimal space. Where it went into the subintimal space, we just pull it back to where the retrograde wire is in the true lumen, and then connect the two together and floss and then treat. And I'm not expecting everyone to do this, but using ultrasound to get access in an occluded artery, especially the posterior tibial, is really a good idea. You take a V18, you rotate it as you go in, and if you don't feel comfortable with that, you don't have to do it. But it's really not as bad as you think. And once the wire goes up a little bit more, it starts to face some calcium, it loops on itself. Then you do the Ginelli technique where you just kind of let it loop and rotate it. And that wire kind of propels itself forward, and it just finds its way all the way up to the pop and to the CTO. And then keeps, if you have a momentum with it, it just keeps going straight. And so we do that technique as well. But your point about single vessel runoff using reentry devices, that should be in everyone's mind. And what I just mentioned right now, that would be like a resort if you want to resort to something else besides reentry.
Yeah, it's pretty nice. I mean, that I personally have not using an occluded vessel that like that often. I've done it once or twice, where it's kind of nice though if you're not going to bag an artery. I mean, it's already occluded, right? You can't do anything bad to it. My concern is that when you're in that occluded vessel and then you want to re-enter into the normal vessel, you want to go true lumen before you're going to attack the actual CTO that you're going to go for, that you can get stuck in your subintimal plane. You can get stuck in that subintimal plane from below. I don't know how often that's happened to you. You've done a lot more than I have, but I could see myself getting stuck in, then in a pop, you're still subintimal. Now you're just subintimal all the way. And
the beautiful thing about it, Sabine, is, and number one, I really commend you for bringing that up. That's a very good point. You have a single vessel runoff. You have a popliteal that's intact. The last thing you want to do is actually do something bad to the popliteal, TPT, perineal. I agree with you 100%. The beautiful thing about having a Ginelli technique retrograde, even if you go subintimal and you go up, it does not affect the lumen of the popliteal because, because of the flow, right? The flow kind of tacks up anything. If you dissect, for instance, it will tack it up. And we've done probably thousands of these between me and Fadi. So we've done a lot of it. And the reason we do it is not to actually avoid using a re-entry device, because we actually gain more lumen from the popliteal SFA. And then that vessel that we accessed that was occluded, guess what? We reverse the access at the end of the case and then recanalize it into the plantars. So now the patient have a new tibial artery into the tibial perineal. But, we do this only if we feel like there's a need for it. And we use 5 French sheaths so much to do most of our work.
Yeah, I started using more, larger access in the tibials after seeing all of your guys' good work. I still overall in the majority, I'm keeping a bareback quick cross catheter or whatnot in the tibial going up and doing majority of work from above. But it has definitely helped to be able to use 5 French catheters and everything from below, especially for complex trifurcation or popliteal work. Absolutely.
And I just want to add one more thing, Sabine. Is like I want everyone to hopefully not misunderstand that what we're doing is aggressive. We don't push anything. When you rotate the Ginelli wire loop, you actually just basically rotating it clockwise or counterclockwise, and it will propel itself. And if there's a problem, or if it stops or it starts to look the different directions, we stop and reassess. So we have not had a major issue with this.
Did your Ginelli wire ever break?
Of course, absolutely. Every wire that we use breaks. Not every day. I mean, not on regular basis, but there isn't a wire that we use that doesn't break. True. And when it breaks, it's 100% of the time it's gone subintimal, and it broke in the subintimal space.
So it doesn't matter almost.
And that the question that I get all the time: do you want to go snare? Like, no. It's a good place,
right? You're gonna get rid of that subintimal plane, anyways.
Yeah, I mean, it's there's no lumen, right, to begin with, and when you leave it in a subintimal space and the catheter is behind it, you get a new wire, and now that subintimal space is glued with that wire that broke off, and then you just go by it, you pass it in the true lumen, and you go up. And I'm simplifying it, but it definitely no matter how many you do of these, when a wire breaks off, Sabine, you always feel bad and awful, and you try to get it out somehow, knowing the essence of intimal space. And we use ultrasound and IVUS, they'll double check that. But, as doctors, we all think alike. We don't like to see anything out of the ordinary.
Obviously. Don't want to leave anything there. But I mean, it looks like, our discussion's pretty clear that these complex, whether it's FemPop or tibial occlusions, I mean, pedal access and using conventional techniques, and some other advanced techniques like Janali and other things can really, really revast these lesions, whether it's subintimal or true lumen. And we are fortunate in this day and age to have reentry devices for some special situations. One we mentioned, single vessel runoff. Something else that came to my mind was, I think there's utility in a iliac occlusion, at the bifurcation. I think Outback or Pioneer tends to be my first choice in those. If it's a flush common iliac occlusion, do you feel the same way?
Oh, absolutely. I mean, we almost never re-enter without the Pioneer because sometimes you get fooled by the lumen that you see, and you think, you just subintimal, right? And then you IVUS and you find yourself way far out. And that's when
extravascular.
Especially if you're close to the carinum. So we always IVUS first, and then we see the distance to the lumen and then reassess. But Pioneer is actually what we use primarily in the uroiliac junction, especially if we're close to the carina. As you know, if you perforate in the area next to the uroiliac junction, carina area, trying to control that is pretty complex, and you're not always as successful as fast as you want. So we always, when we get to that point, we IVUS, we measure, and then we use the Outback. And then with that, definitely we enter with it. And the results are usually great. I'm glad that you brought that up because that's very important.
No, it kind of came to my mind. But then also I was thinking, and we mentioned this briefly before, is other devices to help us cross a CTO, and maybe we could remain true lumen. So you mentioned Wingman. I've never used that before, but from what I remember is that it centers you and you can try to just break the cap in the center. Has that been your experience?
The Wingman is something that we used to think about at the 100th hour, right? You spend an hour trying to cross, and then you get the Wingman, and then you cross in 60 seconds, and you always you just want to hit yourself, man. Why didn't I do it sooner? And the benefit of the Wingman is it's just designed very nicely. People always think, oh, there's a needle in there. Well, believe it or not, Sabine, when you start escalating the wire that you're using and the gram tip on that wire, if you measure it head to head between the Wingman, because, we have a wet lab here, so we always testing devices. So if you use high gram tip wire versus 0.18 Wingman, and the high gram tip wire can actually have a much higher penetration through the vessel wall than the Wingman.
Interesting.
So we use the Wingman now immediately if we have a proximal CTO cap, osteo SFA cap, CTO, or distal popliteal. We go from retrograde with it. And when you start to rotate it and it engages the cap, it stays in the cap. So it's not like it changes its vector. So we used to wait till, I don't know, half an hour, 45 minutes, and then say, okay, let's use the Wingman. Now, if the wire cut doesn't work and we haven't crossed the proximal cap, we'll go straight to 035 Wingman integrate. And we tend to almost always cross. We have not had we have not failed with it yet, the 035 integrate. But I'm sure we will someday, fail with it. And then I just would like to say that we use the ultrasound, so it's unfair for me to say that. We have not failed because ultrasound tells us exactly where we are, what we need to do. But the device is phenomenal as you rotate it. They have a 90 centimeter shaft, so you have complete control. And as you rotate it, you can see the needle tip penetrating the cap, and you have a wire to support it. Once we cross the cap, the rest is easy. So it's an advice to those that want to actually venture into a controlled setting, because safety is first. And if you feel comfortable with it, one of the things you can do if you don't have ultrasound, you do a P and ipsilateral oblique views. And if actually the wingman's still in the same place, you're safe. You can continue.
Got it. Yeah, I guess, just to clarify, in your algorithm, when that comes up, because by the time I'm working on these lesions and I'm already having pedal access, retrograde, I'm probably subintimal on both sides. So I don't really know when that. I don't think the wingman would be beneficial at that point when you're already committed. Is that correct?
Correct.
Right.
I mean, that's a mistake we made for a long time, where we use the wingman later.
Yeah.
And that
Well,
was
you can't. Then it doesn't make sense. You want to use it to cross the cap centrally.
Yeah. So now we try to cross and we couldn't cross. And I mean, if you can't cross with a high gram tip wire and a catheter behind it, based on the studies that were done by Asahi and other companies, I mean, you're talking about 100, 120, up to 160 grams. It depends on what you're using, right? And if you can't cross with that, it's time to shift to something else. And the benefit of the wingman, if you actually watch how it rotates, the tip of it, it rotates almost in a circumferential fashion. Like, so a little bit, people think it just rotates with its OD. Actually, it gives you double the OD of the needle. So when you go back with something else, so you already have created sort of like a daughter and like channel, so you can actually advance balloons or other things or catheters behind it. So that's the value of it. But if you committed to dual subintimal spaces,
then
in the past, we didn't have good success.
That's great. No, it's good. I mean, I think, there's always devices coming out and it's helping us. I mean, sometimes it's diluting and we don't know, we have too much to use and it's hard to decide, but it's definitely nice to hear from your experience and from others to see which situations and everything works, because as your volume goes higher and higher, you start seeing more complexity and you start dealing with more complex lesions. In the future, do you see anything on the horizon in the future for other devices to help crossing large occlusions? Do you think they're going to be so easy to do, like in 5 years from now? Is there going to be some revolutionary stuff? Or
there's a few actually that are coming out. There's one from Europe. It's a CTO device and a re-entry device simultaneously together. There's another device has been worked out by Reflow. That's also a device that's actually CTO crossing and a re-entry device. So companies are starting to get smart. So they're going to give you not just a CTO crossing device, but also if it fails, it becomes a re-entry device. That's kind of cool.
That's cool. Very
you're
cool.
there, and if you're stuck, then you pull back. It's almost like a one-way valve, and then you advance your needle, and then you're in re-entry mode now. But once you go into the re-entry mode, you can go back into the CTO crossing mode, which is fine.
Yeah,
because
maybe you might enter into the occlusion, and then you need some more stuff. That's very cool. I mean, that's one of the reasons I think all of us love endovascular work. I mean, there's just technology left and right, all sorts, and CLI and neuro, everything. It's just so cool to be a part of this.
And the last one that is being worked on right now, this one is really cool. It's when you unsheath it, it kind of like has sort of a spring system or a stent that kind of takes the shape of the artery.
Okay.
So it hugs the artery, and basically it pushes the re-entry device. It's a CTO crossing device first, but if you want to re-enter, you unsheath that, and it releases the crescent stent, and that stent pushes the re-entry device, which was CTO device now, closer to the artery. So actually, the distance to travel to re-enter is much shorter than any other devices. That one I'm not sure how far it is, and the company is working on it. It's kind of, they come and talk to us about it, and then we will try actually in cadavers.
Yeah,
but that one's going to be a cool one when it comes out. And the one from Reflow is really cool. I mean, actually, all of them are really cool because I like how everyone is thinking like we're thinking. We have a CTO device trying to cross. We didn't. We have a re-entry in the same device. So you don't have to exchange no new device, cost is down.
Cost, yeah.
So it cost effective methods.
Yeah. Well, I mean, I think, Jihad, you've been doing some amazing work. It's so nice to have you back on after so long, and it's really helpful for the entire CLI, CTLI community to learn from what you, Fady, and all of ACV, what you guys are doing.
Appreciate it.
Yeah, I mean, I really commend you guys for driving this field on. I learned so much from you, and I know everyone else does. So yeah, I just wanted to thank you. If you have any kind of parting words of wisdom for our listeners, you guys always have such good things to say.
I do actually have a couple things to say.
Yeah.
The CTO crossing is the most important part of treating a patient with CLI. So in the vascular revascularization, really depends whether you get flow to the target organ, right? The foot. So if you don't get flow to the foot, you really didn't succeed, and no matter what you do. So I just want to mention like few catheters coming out by a company called Reflow. So Reflow have some catheters that helps CTO crossing. So actually the catheter itself, the catheters that are coming out from different companies right now, they have CTO modalities in them. They're not CTO catheters, but
Sure.
they're good for support. So Reflow have one, Asahi have one, Terumo has one, and a company called Ayatri. Actually, that's one that's cool because it's called the Boss. It's kind of funny.
That's good.
And
The
and
Boss.
what they did actually that's impressive with the Boss, the telescoping, the 018 inside the 035, they can connect together as a single unit. So when you rotate the catheter, you're rotating both catheters. So the first transmission is to the tip. And it's phenomenal because you can cross SFA pop, tibials, pedal, and go around the pedal loop with the same
Whoa.
combo. So this kind of things I would like to leave our colleagues with to think about these devices, because when we got them and we used them, it was like, wow. So Reflow and Ayatri are the two companies now they have theirs out. And the other two, this 035, 018 only at this point by Terumo and Asahi. The 014 is on the way. So kudos to these companies. And by the way, there's no financial connection with them. I just like really appreciate the fact that they give us what we need. There's not much to use in CTO crossing of the tibial pedal arteries. So I always appreciate the effort they put into it because as you know, it's complex and you don't want to mess the target organ vessels, right? That's the most important thing.
Totally.
So look for these catheters if you're working in the tibials and tibial pedals, because I'd like to say a couple of papers were published. The CTOP showed 67% conversion from antegrade to antegrade retrograde, and retrograde was more successful. Another paper was published. The highest mortality rate for patients with CLI is a CTO that is present at the distal tibials or tibial pedal arteries. So when you see that CTO over there, you got to go after it and open it. So I'd leave you with that. The highest mortality rate, highest mortality rate with CLI patients are patients that have a CTO present at the distal tibials or tibial pedal arteries, and it's published in the CLI journal. So
that's great. And those are the hard ones those are hard, right? I mean, if it's a distal AT, DP, CTO, I mean, they are very hard. And that's great that we're having these devices to come and help us, you know, and all the techniques like you mentioned, Janali, being more opening our methods for pedal and everything. I think it's been a really good time to be treating endovascular work.
Absolutely. And hopefully if you send me this discussion, I can show our colleagues, send it back to you with a PowerPoint presentation to show them the Schmidt access technique when you enter into an occluded artery, retrograde crossing with the Janelli, and you guys can put it on the website somewhere, because it's really helpful to show that there's hope for patients that don't have hope. Because I'm talking to you about patients that come to us with an occlusion in a common ostomy SFA, and then there's no reconstitution. So these are the ones that are worth discussing one day.
Awesome. Well, Jihad, thank you so much. I really appreciate you coming on. I mean, there's a lot of info, and really, I think we have a lot more to discuss these days, and look forward to seeing you and having you on again. Thank you, Jihad.
It's been an honor, my friend. I'm always honored, and I love Backtable. So I look forward to being
Thank
a guest
you.
again in the future.
And yeah, we'll see those slides and we'll get something together. And also we'll work together to post those together. So thanks so much. And thanks to our whole Backtable team. We look forward to having you again, Jihad. Thanks.
I appreciate it. Again, thank you for putting this together.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_Backtable on Instagram, Twitter, or LinkedIn. Backtable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Don.
Michael Barraza.
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Article and transcript support by Taylor Robinson.
And Delaney Aguilar.
Social media and PR by Ann Dang.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.